But well, so Pastor, why don't you just, if you might, just grab the microphone, and I just want to say thank you, all right, for hosting us, but also being of the mindset to have a congregation and a philosophy and a congregation that maintains that philosophy of not being afraid to have these conversations.
Thank you, Senator Hughes, Senator Haywood, and for all of you that are here. We are honored to help host this conversation. It's an important conversation, but we also know I'm here with also my good friend, brother, and staff member, Reverend Leroy Miles, who handles all things health for us at our church and our sanctification department. All of this has great implications for our community, and then the work that you do is always and can be amplified as you connect with the church. Whatever we're trying to do in the black community, if we really take it seriously and really want to get to those people, I think including the progressive prophetic black church tradition is important, and that's what we've tried to be. And so this is just an extension of that. Thank you for being here, and thank you for informing us. Our hope is to learn more about what really is going on in efforts that we might know how to be advocates in the process. You're closer to the data and to the information. We're closer to the effect. But we also need to know from you how we can best use our size and reach to help address this situation. So thank you very much for being here.
Thank you, Pastor. Again, thank you for having this environment where we could logistically have this conversation, but also comfortably have this conversation. It's clear that some of the members at the table are members of your church. We understand that, all right? Just saying, okay? All right? Just saying. But it's important that we're clear about this. We are not in the business in this conversation of attacking anybody. We are in the business in this conversation of having a good conversation, a good dialogue about the realities and the impact of what these potential cuts may mean for the black community. All right? And that's what this is all about. We need to be informed, we need to be educated, we need to be brutally honest with respect to what this means for our community, all right? Because if we gloss over it, then the implications and the impact that it could have for our community are significant. And we must have voice in this conversation. We are the principals and the founders of this expansion in health insurance, all right? We drove this. It was Barack Obama, President Barack Obama, who made the Affordable Care Act happen. His leadership made it happen. We led the effort in Harrisburg to fully expand it in Pennsylvania, all right? When the previous governor chose not to expand it in Pennsylvania, we led the effort for former Governor Wolf to make it happen in Pennsylvania. And millions of people across this country, across the Commonwealth of Pennsylvania, in this city, in this region, have benefited from having insurance that is affordable, is of high quality, all right, and is accessible to individuals. And when we really need to be having a conversation about how we grow that, we're now having a fight to protect what we already have, which is total opposite from where the conversation needs to be going. I asked my friend, my colleague, Senator Art Haywood, if we just make a few brief opening comments. You chair the Health Committee in the Senate in Harrisburg. You have traveled across Pennsylvania around a series of issues, higher education and access. For our community, you've traveled around the Commonwealth of Pennsylvania around the issues around poverty and where it is in all pockets of Pennsylvania, even in those communities where there's more deer than people. Okay, all right, you've been there, all right, and I just want to make sure that you had a chance to just open up with some comments as well.
Yeah, thanks so much. Thank you for convening I was away for the first convening and unfortunately couldn't make it, but very glad to be here today. Thank you, Pastor Waller, for providing the space and the leadership, because the space is one thing, the leadership is another, and really it's the combination that allows us to be here. And so thanks for everyone for being here. I just have a few observations. I was part of the Governor's Vaccine Task Force many years ago. It was clear to me that we had nothing close to a public health system across the Commonwealth of Pennsylvania. Very few departments of health, less than 5, less than 6. Most of them were counties trying to do the work. Very loose affiliation of hospitals, loose affiliation of physicians, loose affiliations of pharmacists, so loose that Dr. Stanford had to rise up and create health access. That's a clear condemnation of having a public health system. And even more so with the closure of Crozier. I mean, that is a clear statement. We do not have a public health system that would allow thousands of people in the Chester and Delaware County community to be without a hospital. That is clear lack of system. And we do have some level of network, and I'm a big advocate. I want everybody to know a single payer. Make sure we do actually have a health care system so folks can get covered and have access. I have a few questions that I'm going to ask around, so I just want to share with people some things I'm thinking. One, access. We have a clear access challenge in the Commonwealth and across the nation. 2, cost of prescription drugs, which creates another significant barrier. And my third is lack of black and brown medical professionals. What's happening at these medical schools and beyond. In this district, we have 14,000 folks who are under the ACA, and they are there because of, in part, the high Medicaid, high premium that Biden put in place, so it'll be more affordable. I got 20,000 people under Medicaid expansion and 75,000 folks who are receiving Medicaid. So this is relevant. It's relevant here, it's relevant across the state, obviously it's relevant across the nation, and thank you for making sure we have this conversation about the impact today.
Great. Thank you. Thank you, Senator Haywood. Devin, I'm going to ask you to kind of get started, if you don't mind. Just introduce yourself and talk about, from your vantage point, what this means.
Sure, absolutely, and thank you so much for having me here. I'm Devin Trolley. I'm the Executive Director of Penny, which is Pennsylvania's health insurance marketplace. I'll talk a little bit about how we work with Medicaid and thought I would maybe share a couple of success stories that we've had over the past couple of years since we were created by the General Assembly to paint a bit of a contrast of what we're looking at moving forward. So our program is there as part of the coverage spectrum for Pennsylvanians. We pick up where Medicaid leaves off. So if someone doesn't qualify for Medicaid based on income, they can come to Penny and enroll in private health insurance coverage where there's on-the-spot tax credits that make that coverage affordable. Many people coming over from Medicaid pay less than $10 a month for a full comprehensive plan that otherwise costs as much as $500 a month. One of the things that we've been able to do is a state-based marketplace, which was created in 2019 by the General Assembly, is we've been able to tailor our approach to Pennsylvania. So, for example, when Medicaid started doing the redeterminations, what we saw is that Philadelphia was falling behind on picking up coverage when they were no longer eligible for Medicaid. So we made a concerted effort to do more outreach, more education in this area. And after we did that, we saw this area exceed the rest of the state in enrollment. Those are the types of local approaches we can take when we see a gap and fill it. Another thing is that we have been benefiting on the marketplace from additional affordability, additional tax credits that Senator Haywood mentioned that were put in place in 2021. This has led to record levels of enrollment for Pennsylvania. We have about 500,000 Pennsylvanians now currently enrolled through the marketplace. And that's in addition to all of the Pennsylvanians who've had been able to access Medicaid since Medicaid expanded as well. So these two programs really work together to help people get coverage when they don't have it other places. And wanted to mention that's also allowed us to focus on sort of the equity of who's getting health coverage. So we know that people of color and Black communities are disproportionately uninsured. Since the additional tax credits went into place in 2021, across the state, we've seen a 47% increase in enrollment. In the Black community, that's 77% increase. So we've been able to outpace enrollment in areas where we know are disproportionately uninsured. And that's what's been working well. So we've been very proud that we've been able to have the state-based approach and being able to really tailor our approaches to the needs of Pennsylvania. Now I'll put that in contrast to what we're looking at moving forward, because it really does change the picture. While we've been thriving up to this point, we are very concerned about the changes that are on the slate for moving forward. The first of which is that those additional tax credits that have made coverage more affordable than ever, they, under current law, expire at the end of this year. If Congress doesn't do anything to extend them, we can all take our bets on whether that will happen or not. If they don't do anything, that will mean 82% premium increases for people who enroll through Penny on average. Some will see double. There used to be an income cliff at about $60,000, above which people didn't get any tax credits. That will come back into play. So their premiums might quadruple. But I would say 80% of our enrollees are actually under that threshold, under $60,000. Don't get coverage through their job, make too much for Medicaid, or not eligible for Medicare. So it's independent businesses, it's small business owners, gig workers, all of those people who don't get coverage elsewhere. Their coverage is at risk of increasing by 82%. So we are very concerned also when, I'm not here on behalf of Medicaid, but we are closely monitoring what is happening there, because I think what you see is that a lot of discussions around how to make it more difficult to stay enrolled in Medicaid, and you see similar things on the marketplace side of not just the affordability, but also adding additional steps in the process to get enrolled. And when I say that, there's savings associated with adding steps into the process. And to me, that it stands out because it's not that there's some improvement to the underlying healthcare system that we all know can be improved. That's not where the savings are coming from. The savings are coming from because they are counting on additional steps in the process to create barriers to enough people that they're just not going to enroll, and that's going to save money. And so I think, when I see that from the marketplace perspective, I'm thinking, okay, how can we make it easier? If they're going to make it harder, how do we make it easier? Because, that is something we can do at the state level of try to reduce the burden of these additional federal requirements. Not going to be able to mitigate that completely, but, it is striking to me that the savings that they're seeing, billions of dollars here, billions of dollars there, are all because they're creating barriers to enroll, not because they're addressing some inefficiency or true value or true improvement to the system. So, we work very closely with our Medicaid colleagues on how we can try to keep Pennsylvanians enrolled across the spectrum, regardless of income, regardless of geography, and, looking at these collective impact of the cuts at the federal level, the expiring law with the enhanced tax credits, and also regulations that are adding additional layers to the cost and to the difficulty in enrolling. We are concerned about it being a double hit on both sides of those coverage programs. So, happy to talk more about that today, but also just wanted to share kind of from our perspective what we're watching, what we're seeing, and are very concerned about going backwards on the progress we've been able to make here in Pennsylvania over the past few years.
Thank you, Devin. RG, you're providing those services, Dr. RG Allen Wilson, all right? You're providing those services. What is it that you would be confronted with as a practitioner? And make sure everybody understands exactly who you are.
Yeah, so thank you, Senator, and thank you for Reb for this opportunity, and Senator Hayward. I'm Dr. R.G. Allen Wilson, and many of my mental health practitioners here, Farida and Dr. Ayla, we all know the uphill climb that we're experiencing. I give leadership with my husband, Morgan E. Wilson, in our nonprofit called Mental Health First Connects. And the goal of Mental Health First Connects is to offer education, awareness, assessment, advocacy, and equity. We know with these cuts, what we're seeing is that Black and brown people are disproportionately impacted, where they're not receiving the mental health services. It is not that our community is experiencing any more mental health issues. We just have less access to mental health issues. We also have really what we would call a traumatic experience or trauma bonds that are experienced, quite frankly, because of cultural mistrust. The system has not treated us very well historically. There is a crisis that's going on in terms of black maternal health and black paternal health. Reverend Miles with Alexia talks a lot about this with regards to postpartum depression and anxiety. And what we know, and many people don't know, is that postpartum depression turns into oftentimes going unaddressed postpartum psychoses. That is when women who are doing the thing that many women and men and families do, which is to expand their families, do not anticipate that having a child means that they are actually going to end up being depressed due to a chemical imbalance, that going unaddressed turns into psychosis. I'm talking about hallucinations. I'm talking about delusions. I'm talking about suicidal ideations. So we are all seeing this in our communities, and the cuts are going to disproportionately impact us. 1 in 5 of us as people of color, black people in particular, have a mental health crisis. What that means, though, is that we don't have the same access to the services that would normally be provided to anyone and everyone, and that we have the right to. And so the goal here, right, is to make sure that many people not only are educated about the mental health crisis, but that we have access. And that's a problem that I'm seeing. I'm seeing it on the level of men, right? I'm seeing more men being interested in mental health than ever before. Reverend Miles can attest to that. Reverend Rev can attest to that. But are they having the access to get the service that they need? More and more we are seeing black men and women having not only suicidal ideation, but they are carrying it out. They are unaliving themselves more and more. We see these calls all the time. And then when it goes to them actually wanting to get help, they don't either know where to go, or when they actually get to services, they are turned away, or they're having a longer and longer wait list. Imagine if you are having a mental health crisis. You are depressed, you're not sure what's going on, you are then more anxious, you're mood dysregulated, possibly having suicidal ideations, and you're told that you have to have a 6-month waiting list just to get the help that you need. It's a non-starter. It may be over by then. And so we have to do a better job of that. Senator Art mentioned this idea of mental health professionals and health professionals of color. We have to do a better job there, because not only do we have an access problem, but there are more people that don't look like us, that we then have to go to those services and they don't understand cultural competency, cultural awareness. They don't understand what is really happening for us. And so someone could be having an experience, maybe a faith-based, a spiritual experience, and that does not mean that they're hallucinating, but that could be misdiagnosed. And so having more people that look like us to provide these services, but these cuts are going to not only disproportionately affect us, but our communities. So that's what I'm seeing on a day-to-day basis. And we get numbers of calls both to Mental Health First Connects, but also to our practice. And we can't see everyone, right? And then when we do try to see the people in a very short time frame, a lot of times they're not able to afford it. So we have a crisis going on that we have to do something about it.
Danielle Brooks, Director of Quality, Health Equity and AmeriHealth Caritas. You research this, you study this, you analyze this, you look at all of this stuff. What are you seeing? What can you tell us?
Can you hear me? Am I on?
Yeah.
Yeah, no, I appreciate that. So Danielle Brooks, Director of Quality Health Equity and AmeriHealth Caritas, also known as Keystone First in the area. And I've been practicing health equity work for over 12, 15 years. And the reality is that this, one, when we talk about Medicaid, I want to make sure that I emphasize that we use the proper language around it. Oftentimes it becomes the stigmatized conversation, but the reality is care that we have the right to, that is necessary, and that is supportive of our communities. One of the things that I study a lot in my practice is maternal health equity. The impacts of not only the maternal process for the family, for the black birthing person, for the black mother, but also what comes before that and what comes after that. So we know that when you have gaps in access, many of these patients are coming in with chronic conditions not treated, chronic needs for behavioral health not treated. And the reality is, in the city of Philadelphia, Medicaid supports 64.6% of all births. These are women, these are people that are trying to have their best health, to welcome a life, to grow a family. And when there are access issues not only to those supportive services, that has a tertiary and downstream impact to the families and the communities. One of the things we know that increased access is better for you. Increased access to prenatal care, increased access to BH services, behavioral health services, increased access to social determinants of health. All of that is critical for having strong communities. So when I talk about the stigma around Medicaid and this access issues and that work, this is our right. This is something that we have the right to have. We have the right to have health. And so this has the potential of making that problem worse. We need to make sure that we are able to have those quality healthcare services, not just because you are pregnant, but prior to that and through that process. And so again, we see that it's such a critical service for the life and bringing of life and love and support in these communities. And we also see this with chronic care. Our communities are disparately impacted by high blood pressure, by diabetes, by other types of metabolic diseases, and these are structural. And so again, this is such an important lifeline and access, not only for the strength of our communities, but to make sure that we have the right to go through life in the way that we want it to. So.
Thank you, Daniel. Let me acknowledge the presence and hand the microphone to Senator Sharif Street. Senator Street has been spending some time. In fact, you got a lot of public stuff going on right now about accessing black men to health issues, but also in the legislature chairs the Banking and Insurance Committee, of which this whole space partly falls into that reality as well. So, Senator Street.
Well, thank you, Chairman Hughes. I want to thank you for the leadership, your leadership in this space, and all things fall in the space of appropriations in the Commonwealth.
That means he's more money for projects.
But look, the issue of health access is critically important, and it is an issue where our communities are often either not considered or we're an afterthought. Sort of, let's design health models, and then, oh yeah, are there impacts on the black community, and can we adjust the model? Becomes the question, and the problem with that is there is a model that was designed without thinking about us, and then we become an afterthought. It is significant, and I'm appreciative that I'm privileged enough to chair the Banking and Insurance Committee, and only in America would healthcare be driven by a committee titled Banking and Insurance, but the reality is that most of the healthcare dollars that will be pushed out of either public or private insurance, so it is critically important. And I'll go back, I'm looking at Dr. Stanford when I think about this. We go back to COVID, and when the city had developed its plan around testing, and a lot of those dollars are coming through the Commonwealth. Where we sit in these spaces matter. In that moment, I remember I got a call from Senator Haywood, who said, I chair the Health and Human Services Committee, you chair the Banking and Insurance Committee, there are no other committees they can send this money through. We need to make sure that my church member, Dr. Sanford, is, and her efforts are not forgotten. And I said, well, I've known her brother since high school, and I also will claim her as well. But in all seriousness, it was an important moment that we sat in these spaces, and what we did and how those plans got crafted, because the original city municipal plan had us as an afterthought, and Dr. Stanford pointed that out. And because we were able to change policy around that, literally we ended up with services where people were coming to our communities to get services because there was a more well thought out model that we had. That is the exception to the rule. The ordinary cases, there are models developed by governments and large systems where we are an afterthought, and then they try and fit us in at best. if there is a thought at all. So I think being proactive about having these conversations is important. I will point out we've partnered with the African Male Wellness Group, which is a group that was founded in Ohio. Looking at Pastor Wall and thinking about that, it was, but a group of black men there gathered and thought it was important. It's become a national effort, and for the last 3 years, we have been working with them to raise issues around health wellness. I was asked for a couple of reasons. One, there's a story about, prostate cancer is a huge issue in our communities. And I was talking with a friend who was organizing, and he said I had a very personal and unique, well, not unique, unfortunately, a personal story around all of it that was typical of what happens in our communities, but not often told. And so when you're a public family, you have a public responsibility. Everybody knows the beginning of the story of the Street Brothers, when my father and uncle got into politics together and their advocacy and their careers. Well, the end of the story also had a lesson. My father and uncle both contracted prostate cancer. My father sought care. Was involved in early detection. Had his cancer removed, and is still full of energy, walking around now. Will be 82. My uncle did not do that, and we buried him a couple of years ago. So you can't have more similar demographic experiences than brothers, only a few years in age apart. My uncle went home to glory because he did not get adequate testing for prostate cancer. My father got testing, and he's still alive. And that was the impetus for the story they wanted me to tell, and part of how I became involved with the group, because they said, we need to tell these stories. Because my father said the other day, he said, had Milton, he said, gone down there with me to get tested, he'd be alive probably today. He said, there's no difference in our circumstances other than I had testing and sought care, and he did not. And so I tell the story so that others will not have that experience. And a lot of these stories are personal, but we have been a public family in every aspect of our lives. From the beginning of my life has been public. So you make the best of the platforms that God put you in a position to have. And in this case, two people whose lives were so intertwined and so public end in such different ways because of whether they got access to care. And so it is really important, and it has become, through the trials of life, more personal. So Chairman Hughes, I thank you and I thank you, all of you who are providing direct care and giving us some information so we can be more informed in the policy decisions we make in that regard.
Thank you, Senator Street. Access matters. Priscilla Posse, Dr. Posse, it's good to see you. All right, National Medical Association, this is all the black doctors all across the country, all right? But you're right here in Philadelphia, and we appreciate you for that, and not leaving, not going anywhere. From your vantage point, what does these potential access issues mean for us? And then when we come back around towards the tail end of the conversation, is always the charge. What are we all collectively going to do about this? But talk to the folks about what this means.
Great, thank you. Senator Haywood, Senator Hughes, Senator Street, thank you for the invitation. Again, I'm Dr. Priscilla Posse here representing the National Medical Association, as Senator Hughes said, the oldest and largest medical organization of African American physicians, and also the communities that we serve, so people that look like us in this room. I represent Region 2, which includes the state of Pennsylvania. We have the largest society in our region, because we also have the largest population of black patients in our region, being in Philadelphia. Also a pediatrician, so seeing children and families in the practice. I'm glad to see Dr. Baker here, another pediatrician, and I'm also a medical director for a Medicaid ACO. So I spend a lot of time not only seeing patients, but really evaluating the strength and the necessity for Medicaid. So why this is such an important conversation, because it is that door to access. Really understanding how much access it is providing in the state of Pennsylvania, just over 21% of our residents are covered by Medicaid. We've heard about maternal health, we've heard about men's health. The population that we've not mentioned that's not at this table is children and our elderly patients. Medicaid covers the lifespan, covers almost 46% of children. That's almost 1 in 2 children in the state. Covers almost 40% of residents in nursing homes. I'm sure many of us have had an elderly family member that have been in a nursing home. Covers 46% of children with special needs, 66% of adults with special needs, right? That is a lot of patients that are able to get covered services by being enrolled in Medicaid. And so when we hear about these cuts, the concern, there's twofold of the cuts here. One, right, is its funding aspect, right? Understanding that Medicaid is both the federal and state allocation collaboration, right? So the federal government will provide funds, the states execute it, but it's a match, right? We talk about the Federal Medical Assistance Program. So the federal government for Pennsylvania provides 55% of that Medicaid funding. So we can think about it to the dollar, right? For every dollar, 55 cents will come from the federal government and the states will provide 45 cents, right? So it's easiest to think if that all that 55 cents were removed, the state is now required to implement Medicaid for the same amount of patients in the same way with now only 45 cents. Right, so we can think about what that will actually do. So number one, it may adjust eligibility. States are going to have to be faced with very tough decisions, right? I think it was Danielle that had talked about patients who may not have an income level that don't qualify for Medicaid. They're able to get insurance in another way. Medicaid coverage eligibility is based on your income level, right? Federal poverty level right now is set at 138%. So a person of one, if you're making $15,000, you're eligible for Medicaid. States may say, we may now have to change that to $10,000, right? So we're going to increase the working poor. That's going to increase those who are uninsured. They may cap enrollment rates, right? Mentioned right now it's about 3.1 million covered in the state of Pennsylvania. They may say we're going to have to cap it at 1 million because we just don't have the funds. That's another concern. It may limit covered services. So currently Medicaid will cover what we call beneficial or required services. That's great as pediatricians. We're going to say most of these services are required. Your well child visit, getting vaccines for our adults, your colon cancer screen, breast cancer screening, cervical cancer screen, right? We now may have to make decisions and say what used to be covered may not be covered anymore. You're now going to have to come out of pocket to cover those services, right? We're already talking about a group that is lower income. They may eliminate 1115 waivers. What does that mean? It allows states to be innovative and flexible with how they spend Medicaid dollars. Really want to credit Pennsylvania that recently passed the Bridge to Keystone, which was continuous eligibility for children from 0 to 6 and those who are returning citizens from incarceration, right? What does that mean is once you're on Medicaid from birth to 6, you do not have to continue, right, to do that administrative paperwork. That's great for the state of Pennsylvania. Those who are coming, right, returning citizens are eligible for Medicaid in that first year, allowing them to have those services, which we know has been a problem. That may now go away because there's no funding for that. Eliminate dish payments. We talked about training physicians, mental health services, right, Dr. Allen Wilson. That may go away. So we're trying to increase the number, particularly Black physicians, healthcare professionals. Those dollars may not be there to train them. And it may just decrease payments overall. So particularly my concern is Children's Hospital here in our city, Children's Hospital of Philadelphia, where I am, St. Christopher's, right, receive about 60% of their services are covered by Medicaid. So imagine a hospital, right, that is now may lose up to 60% to cover children and their families. So that's what we're going to see from an access standpoint, and then we may get concerned about reallocation, right? So again, it's a budget, it's dollars. The states are now recognizing we don't have the same amount of dollars that we did to implement Medicaid, but we know that we still need to do more, so what happens is those dollars shift. Right, so we talked about that 45 cents that's left. They're going to have to make some decisions. And generally what goes next is education, right? That's another large part of the state budget. So are there going to be decisions where now we're shifting dollars from education to cover the health services? And what gets hit first is K through 12, right? Coming back again to our children, right? So now education may be impacted. They can't get into services. This could dismantle the system. So states are really going to have to sit around the table. And I give this example. I think all of us have talked about it, right? Whether you're with friends, colleagues, you say, if you're in a boat, right, and your spouse and your child are in the water, and you can only save one person, who are you going to save? And sometimes it's light conversation, but it's really for people to have that conversation about spouse and child. right? This is going to be real. We're going to actually have to make a decision now about who should get care. Should it be the child? Should it be the adult? Should it be the mother? Should it be the man? Should it be the elderly person, right? Should it be the person who is on the street? Should it be the person who's suffering from mental health? Should it be the person that has cancer? Should it be the person that has heart disease, right? That's if we have a choice to save that person. But I'm concerned it's now going to cut our hands off. We can't even save anyone. I'm concerned we may not have a boat anymore to be on the lake, right? And so this collapse will continue, right, if we're not able to stop that hemorrhaging of funds. So it's not just an access issue, right? It's a concern about reallocation of funds, and where one things go, all things go. And so I think it's really, really important to elevate that it's, yes, the funding will be reduced, but states will have to make decisions that I hope we never have to face about who may be more important or what health aspect is more important, because it's all important. But the problem is some people may not make it to the table, right, to have that conversation.
That's very powerful. And as an extension of that, Deanna, I want to come to you now because you're the Hospital and Healthcare Workers Union, right?
Yes.
You represent these healthcare workers
Yes.
who none of this works
Yes.
without y'all.
Yeah.
Okay?
About 9,000 members we have.
9,000 members. And the care that's provided, and we had this conversation when we did Medicaid expansion in Harrisburg, the employment that occurs as a result of the care or the lack of, the loss of jobs, loss of opportunity. Speak a little bit about that.
Okay, so yes, I have about 9,000 members. So my members are spread over Children's Hospital that she just spoke of, St. Chris. Long-term, we have 60% of our facilities is long-term. So that's all our nursing homes. So of course, if the cuts come, the first thing is going to be, they got the union workers there that's already not even getting paid the way they're supposed to be paid. They got minimal benefits, so they're either going to be laid off or cut. They won't get increases. I mean, we had bargaining now, and they're telling us to do like a wage reopening in 2 or 3 months to see where the fund is going to come from. Our mental health. We have Marikey. I have about 700 workers that work for Marikey, which is adult behavioral health, that live in those residents that require 24-hour care. And they live there, but they're able to have some quality of life because they live in their own houses, they have their own bedrooms, they're not like in a group home, they can watch their own television shows. So there'll probably be less of those residents and more group homes where they put them all together and they can save money. And that's where, those funds from Medicaid gave those folks access so they can have a better quality of life without the group homes, because they are high functioning, but they still have behavioral health issues. And so we have a lot of workers over there, again, being paid minimum, $15, $16. We just got to that, and we back at the bargaining table, and they saying, hey, we don't have any money. We can't make no decisions till we see what these funds look like. So it definitely will have an impact on the folks that we represent. Long-term, behavioral health, and the hospitals, Temple, Jefferson, Children's Hospital, Presbyterian. Those are the hospitals, and University of Penn. So, yes.
So the workers,
Yes.
and I just want us to make sure that we're all clear on this, because obviously not everybody's on Medicaid, not everybody's on CHIP, not everybody's on ACA or Penny, all right? Not everybody. But when there's the ecosystem is dramatically impacted when one part of it starts to collapse, okay? I think, Arj, you mentioned the length of time it takes to get to see someone now. When the system starts to collapse, that length of time will only extend further, all right? And you all know, and we're obligated, I think, to discuss this as well, around issues of access. We're dealing with this transportation crisis that we have in front of us right now. You go past any one of our health systems right now at 5:30, 6 o'clock, 6:30, 7 o'clock in the morning, and they're filled with people getting to work, and then they're filled with people coming for treatment. okay, when your father got care was probably about 6:30, 7 o'clock in the morning at some facility, okay? So we cannot lose sight of how the entire ecosystem is impacted, all right? We cannot lose sight of the employment realities in addition to the care realities. And I want to be real clear, and I've said this in caucus, okay? I've said this in other public spaces. If these cuts, Dr. Posse, that you talked to, you talked about the finances. If these cuts occur, the Commonwealth of Pennsylvania, no state has the capacity to pick up those costs, those cuts. Unless we want to raise taxes. Dramatically. Okay? Not around the edges. Dramatically. No state has the capacity to handle the cuts that are being discussed. All right? And we haven't even gotten into the threats around the core benefit program that is part of the ACA. All right? You know, on your parents' coverage until you're 26 years of age, right? You know, no lifetime limits and all of that stuff. We haven't even broached that conversation yet. So we need to be clear, all right? This is not a issue that we need to ignore and sit on the sidelines of as they are discussing this in Washington, D.C., all right? And the reason for this conversation is to make sure that the black community does not get undiscussed as we go forward in this. Dr. Burke from Children's Hospital of Philadelphia, you want to provide some enlightenment to us, please?
Yeah, so I'm Dr. Michael Luke. I'm a pediatric hospitalist, at the Children's Hospital of Philadelphia. I work inpatient, taking care of children with special healthcare needs, and I work as a researcher also studying the socioeconomic factors that influence children's health and economic potential. And this topic is important to me with both of those hats as a hospitalist and a researcher. And I think about this as a researcher. There are a lot of things in science that are unknown, but that's what's very clear in science is that Medicaid saves lives, particularly Medicaid saves children's lives, and also not only saves their lives, but gives them opportunities to access education and reach their economic potential by getting better paying jobs and contributing to our economy as well. And people talk about, our economists in the research side talk about the multiplier effect and about how every dollar invested from governments into Medicaid yields more than $1 for the economic activity for the state. And I think that's not always talked about, and it doesn't necessarily need to be talked about, because as a pediatrician, the moral imperative is Medicaid saves lives, and that should hopefully be the end of the conversation. But as a hospitalist, taking care of kids with special health care needs, the population that I'm especially worried about, especially in our communities, especially in West Philly, is our children with special health care needs, which now represent about a quarter of kids in Pennsylvania, and that number is growing for good reasons, because we're doing a better job of identifying those conditions early and doing a better job of providing them with novel treatments so they live longer, fuller, healthier lives. And that's very important, especially for our kids, particularly in West Philly, who are dealing with asthma, sickle cell disease, mental health diagnoses. And half of those kids are on Medicaid, if not more. And what I'm especially worried about for those kids, a lot of them do rely on primary health care, Medicaid for primary insurance, but also rely on secondary Medicaid to help those wraparound services that are not necessarily covered with Medicaid. And I'm really concerned that those might be in jeopardy as well. And getting a diagnosis of a chronic medical condition is horribly traumatic for our families and takes a lot of time to process. And when we deal with that in the hospital, the compounded stress of having financial stress related to lack of insurance coverage is not a fair burden to place on our families. Several months ago, I had a patient that was admitted with a new diagnosis of a seizure disorder, which is a life-threatening condition that could be immensely overwhelming for families to take on. On top of that, we found out during the hospital admission that Dad had recently lost his job and therefore lost his employee-sponsored insurance. And we worked with our social workers to get them started on enrollment for Medicaid, and thanks to things like retroactive eligibility, by the time they were discharged, we could connect them with primary care and neurology appointments because we had that 90-day retroactive eligibility to make sure they were enrolled. Now, in the long list of things that we're thinking of cutting, we're also worried about that retroactive eligibility cutting down from 90 days to potentially even shorter, 30 days, which is especially overwhelming for the families that I discharge and have to go deal with a new diagnosis and afford their medications, and also deal with the stress of how do they manage and take care of a kid with a chronic medical condition, and also worry about quickly making sure their forms are all teed up for enrollment in Medicaid. So all of these things I'm especially concerned about, and the strains on the health system. And it's a good reminder that, and I appreciate your point that the cuts on Medicaid will be especially harmful for our community, but it's a problem for everyone, whether you're on Medicaid or not, because our health systems are strained as it is, and they're only going to get more strained moving forward.
Rita Boyer, you're, like Archie, you're doing that piece. You're in the neighborhood, you're in the community, you're on the front line. I'm sorry. Let us know in a very practical way what this means when folks are questioning, can I pay for this? Do I have access? Do I have coverage? What's going to happen?
Just like she said, we're going to see, it's going to be catastrophic. When you talk about suicide, I just got a phone call maybe a week or two ago where someone committed suicide. So we're hearing those things more often than not. And we do, at the Black Brain Campaign, we kind of do a little bit of everything what people touched on. We have partnerships with different schools because we provide training for clinicians. That's because we want to see more culturally competent clinicians. That's an issue because it's not enough of us to do the work, which ultimately impacts the clients that we provide services for, because we provide services for a wealth of people in the city of Philadelphia and in the surrounding counties. So it's definitely an issue because our services are free. We have a waiting list. We try to get to and when somebody just talked about the extent, I'm afraid of what the waiting list is going to be like if we don't have that. We try to meet people where they are and providing these services in a timely manner, but it's going to be, it's overwhelming, not just for the clients that we see, but also the clinicians that provide the services, because we put so much on them. You have to see the clients. It's part of your responsibility, but it's only so much that we can do. And it's hard. It's hard. We try to. We have partnerships with other organizations. We're providing trauma groups. Trauma groups, violence groups. We just started prenatal groups with moms. So it's like we're trying to meet the needs of the community, but it's just becoming a lot. It's overwhelming. And I'm afraid, like, what's going to happen if we don't get these dollars, because that's how we've been able to survive and provide the services that we provide.
Dr. Stanford, come on. I know you sit there, you're steaming, okay?
This is true. How
Okay.
was that my body?
Know you very well.
So I'll start by saying it was interesting, Senator Street, to hear you go down that memory lane, because I still remember being outside the masjid when Senator Haywood came to say, how can I help? I still remember that. And I want to thank all three of you, and I also want to thank Pastor Waller, who, in the midst of it, and we didn't know what was happening, to open your door in your parking lot, and Reverend Miles to be a conduit for us. Because with the funding you gave us, when we talk about access right now, we have 2 locations, where 5 years ago we didn't have anything. We had the parking lots of the church, and that is the importance of the faith community. Because it was something that we owned, we were able to mobilize quickly, and that saved lives, collectively saved lives. So what do we do? Are we in the what do we do? Okay, so
You got the mic.
so one, obviously, and this is not a surprise to anyone, but we got to own more of our stuff, right? We wouldn't be talking about, my staff came to me and said, oh my gosh, what are we going to do? They're cutting fundings. I said, we are not going to do anything, because we're not relying on federal funding to keep our doors open at this point. I work hard, I hustle hard for philanthropy dollars, for donations, for partnerships, for contracts, and we're year 5 and we're still going strong, obviously with your support as well. For the prescription drugs, we enrolled in a cost plus drug program with Mark Cuban. If you guys don't know about it, healthcare systems and so forth, you need to enroll, you need to be licensed, you need to have a DEA, but we're able to buy medication for like 2 cents. Cheaper than prescriptions. Some of my colleagues at Penn are saying that's how I get my prescription drugs for my parents now. They're not even going to CVS anymore. So thinking outside the box, those are some of the things we're going to have to do. And I'm also looking into getting a pharmacy, but that's coming soon. The second is that when we talk about we need more black doctors, there was an article on the cover of the Tribune this morning with one of my mentors, Ken Davis, talking about how the endowment that he and his wife raised, their own money, millions, that they did in partnership with the university has now been taken. And because, yes, Cincinnati, and because it was only for black doctors and they didn't want to change the title and they did it in concert with the university can take their money. We just talked about this. So what does that mean? When the endowment is done, it's done through Enon. So you control the money as people raise it. It's great to have those partnerships and affiliation, but when things like this happen, you lose what your investment has been. And he's struggling with that now. The other, you said, do I have a student? I always have a student. Ms. Bethel is a Master in Health Administration major from the University of Alabama. We always have to train the next generation. Some of the people who were residents and medical students during COVID are now finishing their residency, and some of them have come back to work in our center, and I've been able to employ them. So I keep trying. When someone says they're interested, they have the aptitude, we assess that, we pour into, we gotta invest so I can retire in 10 years and they can take over what we're building. The School District of Philadelphia, I applaud Dr. Watlington, who has said, even though we get federal funding, we are still mandating vaccines, we are still giving physical exams in our schools for the children, and they have contracted with us. So we are going into the schools. We did Dobbins, Girard College, even Cheltenham High School comes to us to say, hey, we got seniors about to graduate. Can you help them get their vaccines to graduate? Can you help them get their physicals? We contract with them, and they're not rich, but those contracts for us help keep us afloat, and it's also serving the community. We also contract with Triumph Counseling. Many of you may know Kyrie Blackman. He has his counseling service. He's giving culturally competent therapy, and then we can support him while he supports the community. So all pouring back. For the folks that work at the institutions, I saw CHOP and Temple and others, is letting your leadership know that this is happening. CHOP has way more resources than St. Chris, we all know, and having a conversation. So when this happens, are we prepared to accept the patients that go to St. Chris? And I know Madeline Bell well, but having a concerted effort, where's my other CHOP person, Enme, and you guys coming to her, and saying, let's talk about this, let's be ready, let's be at the top and not thinking, what are we going to do, but be prepared. They don't want a bad look of closing a door of children and families when they can't get the care, because that's where they're coming, right? There was already the time when Health Partners wasn't accepted at CHOP. That's only in the last 3 years that they've been able to go there. And so that conversation needs to happen now in the hospital. In terms of at the legislature level and with Penny and so forth, even if 47 says we're doing this, at least to say, can we have a transition period? Can we identify who the people are at greatest risk and have a slower rollout? You could lobby for something like that. Okay, you're not going to change it. Let us prepare our people. Once you know who's going to be impacted most, that we get together again and you say, this zip code, this community, the age groups most impacted are 65 and up, those 18 and under are, so we can then mobilize to provide those services, because you'll know who's going to get hit first, and then that's when we can really start to strategize. But if they're going to do it, rather than waste time, please don't do it, okay, give us the time we need to inform folks. And then that's when, from the pulpit, you know, Pastor Waller can say, okay, this is what's going down. This is where you can get medicine. This is where you can get behavioral health. This is where and it'll be on our website, which will allow us to. And then the final thing, I said faith, community, behavioral health, shared experience, child prepared. What I can do with my platform, and I would encourage all of you that have, you know we're about to have sworn in a Surgeon General that does not have a medical license, that did not finish a residency program, but yet is about to be Surgeon General of our country. So what I have personally decided is
Let
that
me interrupt.
yes.
Everybody in this room is more qualified to be the Surgeon General than that person.
Yes, and and we're talking about
Everybody in this
DEI.
room-
Don't even get me.
Everybody in this room is more qualified.
That is
and I'm
correct.
saying this so y'all don't have to take the hit, all right?
Yeah.
Everybody in
That
this
is
room
correct.
is more qualified to
That
be the
is correct.
Secretary of Human Services,
Well,
all right?
Right.
Who just had his children swim in the creek in Washington, D.C. Rock Creek Park, was
Yeah.
that it? All right?
Yeah.
That has known pollutants,
Pollutants and
bacteria,
bacteria.
and sewage running through it.
correct.
So how do we expect, I said
Right,
it, I
right.
said it, all right?
Right.
No one else in this room said it. How we expect that person to make good decisions for our families when they can't make thoughtful and good, smart decisions for
Exactly.
their own children?
And that's where all of our voices are going to be critical. And so every time she speaks, I will make a TikTok, I will make an Instagram, it will be posted everywhere. I will reach out to all my media folks because we cannot allow that narrative to be the powerful, pervasive ones when our kids are getting measles and polio in 2025. So it cannot be, and I will point out that she's not licensed, that she's not board certified, that she never finished a residency. She cannot be our nation's doctor when she has no credentials. And I will point out mine and direct them to look at them. And so that's what I'm going to do personally. And then finally, with the book I wrote, it was the textbook at Penn. So I was able to, as I taught that class this past semester in the bio department, be able to point out and educate our next generation of leaders. They're also using my book at the University of Chicago. So telling those personal stories when people say, I don't see how it happens, I don't see color, I don't understand why racial concordance is an issue and why I need to have a doctor that looks like me, when you can show how it impacts and publish now, you made these cuts, we had this many kids, we had this many people in the ICU. So we have to combat when they do these things. We have to have also the data-driven, Dr. Luke, you talked about the data, show how it's impacting and take the emotion out of it. Right? My attending used to say, without the data, the chatter don't matter, right? Put the objective data out and show when you did this, it impacted my patient population this way. And we continue to do that, but we can't be silent and just hope that in 3 years or 4.5 years, it's going to be better.
Kathy Levins,
Senator.
let me get
I got you.
Let me get Temple on in the conversation, and I got you, Brother Leroy. Kathy, your Temple Hospital is the hospital that probably in the city and the region has more government-sponsored care, government-paid-for care. Number one in the state. When you hear these cuts being discussed, what does this mean for what you can provide for the folks who are coming in and out of those doors?
Well, can you hear me?
Just hold it up.
Okay. So it was pretty powerful for me to sit here and listen to everyone today. I mean, every day I get up, I think of, what can we do to access care? And all three of you, I want to thank you for your support for Temple Hospital and for Pennsylvania's hospital in general. And really, do I have to hold this? Oh, no, you don't have to hold it. Yeah, okay. I think I was turning it off. just want to thank you because I think that some of the things that Pennsylvania, this is a little bit of an optimist, I'm going to start on an optimistic note, is that Pennsylvania really saw things coming, and we did a lot of things at the state level with your support with the Medicaid program, with the provider taxes, with the state directed payments, with the average commercial rate, all these things that are being debated as we speak, to help maximize the amount of revenues that could go to Pennsylvania hospitals. So I'm encouraged somewhat that we at least have a decent starting point. But recognizing how steep these cuts could go, that has me very concerned. The work requirements is one. I mean, needless to say. We do, I think everyone here is pretty familiar with Temple Hospital, but we're 86% government pay, about 46% of that at Temple Hospital, Maine. We talked about behavioral health. 85% of our behavioral health patients at our Episcopal campus are covered by Medicaid. Talk about women maternity, 85%. Pediatrics, 85%. So we've really been working the past few years to build up that infrastructure. We're going to have a grand opening of a brand new, beautiful crisis response center tomorrow. And I think about those investments that we've been able to make, a new women's hospital coming soon. Chestnut Hill Hospital, Senator Haywood, thank you for fighting, for holding our feet to the fire, getting us at the table, and it's, that hospital remains open and growing. So my concern is just really, we're going to navigate through this, and I just want the people at this table to know that we are committed to working with you to continue to find ways to make sure that our community gets the access to very high-quality care. Every one of our physicians accepts Medicaid. That's not the case at all health systems. You must accept patients when they come to your emergency department, but you don't have to accept everybody in your physician practices. So we're committed. We remain committed. We've been advocating, and I'm happy to say I work with our colleagues at CHOP and the other hospitals. One thing that we've been doing is when we meet with our Congress members is also collaborating with some of our rural partners as well, because there's some people on these committees, in the Energy and Commerce Committee, a certain congressman in Altoona that is very influential. So we have been going around with places like WellSpan and Highland Hospital out there in Western Pennsylvania to try to let them understand that there's very much similarities between vulnerable communities. And we hope as this unfolds that some of these messages, got out there.
I would just add, and thank you, Kathy, the Temple's presence and Senator, we all can speak to this, Senator Street, obviously, that's, home base. In these rural hospitals, and I'm going to get to you, Reverend Miles, in these rural hospitals, and I'm going to be cautious about where I go with this, but I think I've said this before, the rural hospital in many of these communities, which relies so much on government payment, right, is the largest employer in those communities. Not just the largest health provider, it's the largest employer. And their elected officials are voting to make these cuts. Now, my mother, don't cut off your nose to spite your face. Maybe some of these folks need to listen to my mother. All right? It's done her well for, I can't say how old she is, but it's done her well for all these years that she's been around, and that's had an impact on me. But partnering with them is important, but having them speak the truth to their elected representatives who are advocating for these cuts is imperative. It really is, okay? Because you talk to their constituents, they're facing you know what? But their people representing them are glad to go along with it.
I would just say that what really makes me proud is the people around this table who get it and understand that. I'm not so sure that the communities in some of these rural, my colleagues are advocating. I don't know that everybody in these deep pockets of the state really understand what's about to hit them if these cuts go through.
We wind up suffering. Let me get to Reverend Miles. Go ahead, Reverend Miles.
I have to leave early, so I just want to say this a real time, which you will probably say on Sunday. Tell folks to stock up on get a 90-day supply of their medicine. This is real talk. Schedule your colonoscopy, get your mammogram done, get all your cancer screening done. Any appointments that you've been putting off, this is not the time. I think that's a real time something that people could do, especially the meds, the procedures, because that's what's going to cost a lot, or they're going to have to wait a long time for. And I apologize. I yield. Thank you.
No, you and I, and thank you. And again, thank you for the time. And the anger is the same, even with the smile. And we echo a lot. We're clear that Calvary's not coming. We, as a church, have been making bricks without straw for a long time. You alluded to 12 to 15 years, but we were going back when it was health disparities. We were doing this work, and then now it's health equity, and then now we understand it to be population health. So,
to be clear, Philly is the center of health equity.
I
always quoted that in 1901.
No, I got you. I got you. No, I agree. It's just been interesting to watch the transition as a church. Being in the center of all of this, and we've never shied away from any of it. And so the point I was just going to make is now we're talking about population health, because sometimes we're afraid to use health equity in a sentence. So we're smart enough, we'll transition if need be to population health because we're not afraid. But back to the bricks without straw, it's been a collaborative effort with so many of you around the table, CBH, and so many of you do get it, and I agree, many of the folks around the table get it, but you also understand the impact that the church has, specifically the work that we've done when you've partnered with us. So as a researcher, we can help you. When you're talking about clinical trials, we've been there. Genetic testing, we're having these conversations and have had them for 5 or 6 years as a black church, which is pretty much unheard of. And we're doing the work. So use us, as Pastor Wall alluded to. If you want to do it, and we've done much work. Alexia is my niece with Cocoa Life. So, and Cocoa Life is us, and we are here. And the 40 doulas that we did 6 years ago, and now is over 300. The doula, maternal health. So, I guess the point I'm making is I'm sitting here, and I am frustrated, and I understand you all's work. But I also understand our obligation and our responsibility. And we don't have to mince words. You may have to.
No, never.
I'm just saying. But we don't have to. And so we have a strategy that we're proud of. So Sharif, yes, the male wellness piece, I'm with Demir. We're working together collaboratively. And so you'll do 500. We did 800 last week. But we're 17 years in with our men's Know Your Numbers. So when you're talking about stack up on your metabolic screenings and others, we've offered it for free for 17 years. It's because of Dr. Edith Mitchell and the relationship that we had. So we know what to do. She's taught us, some of us, extremely well and taught us how to play the game extremely well. So I guess the point I want to make is we understand what's going on with NIH. We understand it. We understand the impact that it will have, is having already, because there were a number of relationships and deals that were on the table that went away even before the election. So they went away in August, September, as if somebody knew what was coming down the pike. And we prepared for it. We structured for it. We understand it. And where we can be that force multiplier, we're doing it. So as a church, and as I hear you around the table, we are not reacting the way that you all are. And it's not out of naivete, is that the word? Yeah, thank you. Not out of naivete, but it's out of, we get it. And we've never relied on, and Pastor, he has this word. He says, we're not going to accept any money that would keep him from being full-throated. I don't know what that word is, but he is a doctor. He gets to say those words. He made it up. But the reality is, we work in collaboration in such a way that it would never keep us from doing the work unapologetically. So it is with Black Men Heal, and we've worked together as well on mental health and its free services. We've underwritten prior to the pandemic and during the pandemic mental health support. So the reason that you can say, and we can talk about why men are so responsive, it appears to be, is because of the work that we're doing collaboratively to reduce stigma, to provide access at no cost. So please, all I'm saying is just please use us, and where we found it to be true. So it's also in pharma. There's some wonderful relationships with pharma. Amen. Yeah, you're shaking your head, right. And biotech as well, that we've entered into these relationships with in a way that it's the way my mother used to hand me money when my father said no. Ask your daddy, he said no, and then she would ball the money up and then kind of hand it to me, and don't tell your father. That's kind of how we're experiencing some of this type of support, where persons aren't doing it publicly, but they are. Here you go, man. Keep doing what you're doing. Here you go, Enon. Keep doing what you're doing. So for us, it's about being creative. It's about shining light in darkness. And I resonated, Dr. Stanford, when you talked about Keith Davis from Cincinnati. I saw the same article and reacted. These strategies are deeper than what we see. It's addressing Black men in white coats. It's understanding that there was a study that came out in April of last year that talked about when there's a Black doctor in a county, even if the residents don't see that Black doc, it improves health outcomes. So it's deeper than what we see. Yeah, we're taking the cuts, but it's cuts that we want, that they ultimately want to injure us. And this is why we stay vigilant, not even hyper vigilant, just vigilant. We watch and we stay aware of what's happening around us. But let's have the conversations. I'm so glad, because I've been trying to meet you for a minute for a lot of different reasons. But it's those collaborations, and then whenever you see my stuff on LinkedIn, it's always a rising tide lifts all ships. And I believe that to be true. And where you may not have the ability or the capacity to say it out loud, we can have sidebar conversation and improve outcomes. That's all I wanted to say. No. And just get it off me so we can all, y'all can say whatever else you need to say. But, and then you might want to hear from Sister Bradshaw, because she has a lot to say.
I'm certainly going to call on Sister Bradshaw, because I couldn't, Tiffany Wilson would not allow me to have a meeting like this without calling on you. But I want to call on Dr. Baker. And resiliency is a power, but part of resiliency is pain in that, right? Because you got to get hurt to bounce back, right? And we all need to be careful. I would suggest that we all need to be careful about we're a resilient community. We'll bounce back from all of this. You know, that bounce, you know, the ball is going to come back up, right? You know, we're in the playoffs right now with basketball. The ball, you dribble the ball, it's going to come back up. But it hits the ground before it comes back up. And there's a pain there, all right? And so we will come together, we'll work together, we'll unify together, we'll try to respond to these issues together. We need to let folks know who are making these decisions against our interests, okay, that there's a pain here, all right, that we didn't start off causing, that you're driving. So, Dr. Denise Baker, all right.
Okay, thank you, Senator Hughes. I just wanted to state from a pediatrician's point of view that I'm seeing the end result of all of this. The Department of Health and Human Services, they are supposed to protect the health and well-being of Americans, okay? So, having said that, what Americans do you think they're protecting? Okay, that's the big problem. You know, this cut is going to cause a decrease for minorities, for the poor, for the Black, for all of us. in so many words. Everyone here is concerned, so it's for all of us. So that goes for the public health, which is the vaccines, okay? And thank you, Dr. Stanford, for stepping up when we needed you with doing COVID, okay? It also will affect medical research. We have a long negative history with medical research, but however we do as blacks, we need to have medical research and we need to step up to the plate so we know what medications affect us and how well or negatively they affect us. The Food and Drug, the FDA, there's so many foodborne diseases that are coming around, and they're going to cut those things also. So you can imagine what's going to happen. Substance abuse and mental health. Stress. We all know about stress, and it's really a thin line of stress. You know, stress, we have a fight or flight type of mechanism within our systems, and we're only supposed to use that every now and then. And the majority of us, we are stressed all the time. We always have that fight or flight mentality, and it's killing us because that's increased cortisol levels. Those increased cortisol levels do all sorts of things, negative things to our bodies, to our systems, okay? It increases your blood pressure. It causes diabetes, okay? It increases your weight, which increases obesity and the adipose tissue around your abdominal area, which also affects all of your organs. So it's just a domino effect that occurs with all of this stress, and as a result, you know, with the decrease in the cuts, you know, I mean, we all know the mission, okay? And the end result, the mission is extinction, which we're not going there. What does it say? We're not going that way. But that's the reality.
Yeah, go ahead.
Yeah. Dr. Stanley, before you leave, I just want to make sure everybody knows, we haven't lost yet, right? So there's a battle still going on about what will and will not be cut. Some relationships with these rural legislators may help us. We got two legislators who barely won in Scranton and in Allentown. And there's an effort to put significant pressure on them. Those are purple districts. So I don't want anyone to leave the room thinking that we have already lost on the Medicaid. There is a fight in which we need to engage, and this conversation can help us in that fight. But I am been in so many conversations with people surrendering before the end. We cannot, please do not surrender before the battle is over.
Very, very important point.
Yeah, briefly, I think Senator Haywood makes an excellent point. This battle is ongoing. There are lots of efforts, some of which are partisan, so I'm not getting into it right at the moment, but to address making sure that there are pressure on those legislators. Remember, the Speaker loses 2 votes. He does not have the votes for the bill. And there are 12 Republican members sitting on the fence at this moment. And so the last time that the orange guy was in the White House, he was unable to repeal Obamacare, even with a Republican House and Senate, because of the level of grassroots pressure that was placed. And a word about the Medicaid expansion population, those are working people who didn't previously have health care. In Pennsylvania, 700,000 of them. And yes, many of them are the type of folks who live in West Oak Lane, folks who live in Germantown. But they are also the people who live in many of small town areas, places where they voted heavily for Donald Trump and for Republican members of Congress. And so one Republican congressperson was being asked to vote on this, and another state said 36% of his district was affected by Medicaid expansion. It is not, if we do the right kinds of education, it is not a foregone conclusion that they're going to be able to get the congressional votes to make these cuts. The margins are slim, and so while we do want to be prepared, we don't want to give up the fight. I think the things that Kathy talked about around partnering and explaining to rural folks that this means you will lose your health care, and maybe they don't see the bus coming, but that doesn't mean that if you say, hey, look, they won't realize the bus is going to hit them, and in many cases hit them first and harder. So we need to be really clear because in this case we're in the same boat, and with those folks, whether they like us or we like them, we are in the same boat on this. And so it is not a foregone conclusion that these cuts will happen. We need to remain proactive and vigilant.
No doubt about that. Ayanna, please join this conversation.
Hi, everyone. Ayanna Bradshaw. I'm president and CEO of Access Matters. So we are an organization that's been around for over 50 years supporting sexual and reproductive health. And so one of the things I always like to emphasize is that it's such a critical part of healthcare. And, you know, sometimes it's seen as something separate and different. But for many people, sexual and reproductive health services is the first entry point into any type of healthcare. And we are concerned about the state and the future of family planning services in particular. And these are services around STI testing, pregnancy testing, infertility care, things related to free and low-cost prescriptions through 340B. Many of you may not know Title X is the only federal program that supports family planning services in the country. And currently, the Title X program in southeastern Pennsylvania that we have been leading for since 1971 is withheld. And so this is to all of you who are talking about, you know, let's not give in to defeat. We can't, because this is critical services that people rely on, and people who look like you and I, who folks who may be underinsured or uninsured, who without Title X would not have access, would not be able to get gynecological care, would not be able to get a pap smear, would not be able to get a breast or cervical exam. And so without these services, we know the end result will be illnesses that are unnecessary. We know that the end result could be death if someone was not able to get a breast cancer screening. And so I think our voices are critical at this time. We have to continue to spread the word, to your point, making sure that people know that this is not just a southeastern Pennsylvania issue. Our funding is withheld right now in southeastern Pennsylvania, but this is an indication of what could happen nationwide. And so this is a time for people to speak up, for us to share with those who may be in different communities and rural communities that if this happens to us, this will happen to you, and this is what the long-term impact would be. And so I'm in it for the fight. I know we all are, and we will not give in to the things that are trying to stand against us at this time.
Thank you, Ayanna. I can tell Tiffany that you were a full participant in the conversation. Thank you very much. Donna Bailey, you spoke at the last gathering that we had over at the Science Center. If you want to reiterate that or make it even more focused, okay, on what it is that we're talking about here, please go ahead and do that.
Thank you, Senator Hughes. Can everybody hear?
Yes.
So hi, I'm Donna Bailey. I'm the CEO of Community Behavioral Health, or CBH, as we like to be called. We are the behavioral health Medicaid managed care organization for Philadelphia. So all we do is Medicaid, 55% from the state, the rest from the federal government, the rest from the state. We have no city dollars. So oftentimes people think that there's a city contribution to our budget. There isn't. So anything that's going to happen is going to directly impact CBH. Let me tell you a little bit of the story about a perfect storm that we've been experiencing that doesn't even have anything to do with what might be coming in terms of these cuts. So for calendar year 24, we ended the year with a $101 million deficit. We are on track for calendar year 25 to have a $31 million deficit. That's a combination of inadequate rates and declining membership. So our revenue is based on enrollment. There were 100,000 Philadelphians who lost coverage when the end of the continuous coverage from July 2023. We're expecting that trend is going to continue, which will directly impact our revenue. So what has that meant for us? We've had to squeeze our belts administratively. We've also had to pause rate increases, as I know some folks who are in our network know. We've had to pause service expansions. We have a pay-for-performance program that we typically have dollars associated with good performance. We're not able to offer those dollars this year. Just in the last week, we've had 2 providers announce that they're closing. I know folks may have read about the Wedge. They serve 1,900 people, most of whom are Black or African American. They also have 150 staff. Now, I'm confident in working with the leadership of the Wedge that there's choice for people to go. But as agencies begin to close, I worry that there won't be choice. So that's happening even before these, impending cuts and policy reforms that might be coming. So what are we doing? Because I, too, am encouraged that we're going to get through this. There will be a recovery, but it's going to be a really challenging 18 months to 2 years. In fact, I started off my day with a very sobering all-staff meeting, painting the reality of our situation with our staff, but also wanting to encourage people to keep their minds and hearts on our mission. And so we are trying to work very intentionally with the provider network, communicating that it's going to have to look different. Like, if CBH is going to survive, we are going to have a smaller network. We have 230 providers right now, not going to be able to sustain 230 providers. The Wedge, Interim House Inc., which is just on Upsall Street. Folks might know that program. It's a residential program, drug treatment program for women, have announced that they're closing at the end of July. On the way over, I got another communication from a provider. It's not public yet, but this is a provider that delivers children's services. These are just 3. We expect there will be more. What we want to do is work with the provider network to do this in a more strategic, planful way, understanding that as organizations, they have to make their business decisions, and we respect that. But we want to sit down at a table with the agencies to talk about how do they collaborate differently, right? How, if one provider does something really well and something else not so well, maybe they divest of that thing they don't do so well and collaborate with another organization. This is the only way I see us coming out of this, with the infrastructure to get to the other side. Because I fully believe that we will be able to withstand this, but it's going to mean a dramatically different network. It's going to mean that people aren't always going to have the kind of choice that they want. We've been really intentional over the last few years of growing the network and really investing in community-based organizations, organizations that reflect the population that we serve. And so I'm talking about minority-owned and led organizations. I think that's where the brunt of all of this will be. But we are really trying to be strategic and intentional about what we're calling this contraction of the network. We're also not going to have the staffing complement that we have right now. And I certainly didn't get up and talk about layoffs, right? Because who wants to do that first thing in the morning? But certainly did talk with people about doing more with less, not filling positions. Our leadership team will not be taking any cost of living adjustment this year. Really want to be able to do something for our staff because they are doing the heavy work that I know many of you at your organizations understand what that looks like. So intentionality, but definitely really difficult decisions about what the network looks like, who gets served, where they get served, much of what you all have already commented on.
When you say 100,000 people less have signed up for your services, where are they getting, where they're just...
Great question, Senator. We believe that some of them might have been a part of the expansion population, right? And so maybe they've gotten employer-sponsored coverage. But the data that we get from the state doesn't really tell the story because we can't contemplate where these people have gone. We think that maybe there are some procedural or administrative disenrollments. So we understand it's really hard to get in touch with county assistance offices. And so we are doing a campaign right now around outreach and education about, if you're disenrolled, here are your rights, here are some resources, but 100,000.
100,000.
Just in Philadelphia.
Just in Philadelphia. Cheryl Bettergo, you were the health commissioner for the city of Philadelphia. You're now at Penn. What, from your vantage point, right? And you, COVID, the whole stroll. What is this saying to you? And what is it that we need to do, all right, while we're being resilient, while we're working with one another, while we're restructuring systems to make sure that we keep the safety net, as strong as possible? What do we need to be doing? What lessons did we learn?
So first, thank you for convening us and for really lifting up this issue. And thank you also, Senator Haywood, Senator Street, and to Reverend Waller and Reverend Miles for all they do. I want to lift up what Senator Haywood said. It's not time to plan for what we do. If we reach that point, we will all have to pull together and we will make this work because we are strong and we are resilient. But it's not time for giving up. It's time for fighting. And that's what we need to do right now. And I actually really want to focus on the Medicaid work requirement proposal because I think that we cannot give members of Congress a pass to make that seem like a tweak or something minor. And, I don't know if others saw the op-ed in the Times from RFK Jr. and Mehmet Oz and some other authors, but they're depicting people on Medicaid as people asking for a handout, and as if the work requirements are helping people to be independent. And I worked in our city health centers for 12 years, and I took care of lots of people who became eligible for Medicaid with the expansion. And I am feeling particularly grateful to both of you for getting that to happen in Pennsylvania because it meant so much. But the idea that my patients who worked often 2 or 3 jobs and looked after kids and looked after parents need help from very wealthy men to achieve independence is laughable. What they need is healthcare access so they can work. I just want to share with you, and I think in stories, one story from a longtime patient of mine who had diabetes and just, with the medications we had access to at the time, could not keep her sugars well enough controlled and had diabetic retinopathy. She was at risk of going blind, and she needed a procedure that we didn't have a way to get for her without her qualifying for Medicaid. She worked cleaning houses, and I will say lots of my patients at the city health centers had jobs for which they would never get health insurance until that Medicaid expansion. Lifelong, cleaning houses, taking care of kids, home health, what? But anyway, but I begged her, and she was not the only patient in my career that I've done this with, I begged her to stop working so that we could prevent her from going blind. And like every other patient I ever had that conversation with, she said no. Why did she say no? Because she had to keep a roof over her kids' heads, and she needed to keep food on the table, and so she was going to work as long as she could work, and she went blind. And the idea that she needs help with her independence from RFK Jr. It just makes me so furious. I don't know what to do with that. We need to take this narrative back. Medicaid work requirements are not benign. The people they put most at risk are people who are not highly literate. That's a lot of people in our country. They are people who don't have internet access at home. If you make minimum wage, you can't afford internet. How are they going to report? Are they going to have to go into the office and miss work and miss paid time? This makes no sense. And, by the way, they're super expensive. Georgia spent $40 million implementing. Arkansas laid thousands of people off their Medicaid. This doesn't work. There's no proof that it increases employment. And it's just insulting to the working people of America. Sorry for the rant.
No, don't apologize for that. Unemployment rate is already about 4.1%, which basically means everybody's working already. I know, Senator Haywood, you wanted to...
Yeah, on the work requirements. We've had a number of conversations about the work requirements in Harrisburg. A couple things. The states that have work requirements all reversed them.
Yes.
And they reversed them not because they felt better about the folks who were not getting health care. They reversed them because it was too expensive for the state.
Right.
Because to monitor the work requirements, the hours, every week for thousands of people means that the state has to hire a bunch of people to keep track of the work requirements.
Right.
And all these states say it's too expensive to monitor these folks, and they all reversed it.
Yes.
Now, So all the experience in the United States of America with work requirements is repeal. Don't do it.
Thank you, Senator Haywood. Jim, you deal a lot, and you have for a long time, in the drug and alcohol space, okay? And folks who are suffering from addictions and everything in that space. A good friend of many of ours, Deb Beck, called me frantically in the early part of this process just to remind me and us, there's about 112,000 people in Pennsylvania who are suffering from the addiction, who are getting coverage from Medicaid. You work in this space. What can you add to this conversation?
First thing I want to say, I'm Dr. Win Baker's husband.
Yes.
That's the first thing I want to say.
Yes.
I'm her administrative assistant. I help her with the black doctor, so I want to get on the table
and
first.
And the honey-do list as well.
And the honey-do list, so yeah. But, Don, I remember when CBH used to have an investment fund.
Yep.
They used to make so much money that you could appeal to them to get some money to help with stuff. So it's really tragic to see what's happening in that space. And I also happen to chair Eagleville Hospital's board. So I've been at this for a long time. It's going to really be tragic to see people that aren't going to be able to access services through Medicaid to get help for addiction, which is a horrible disease that's misunderstood, but that leads to family loss, that leads to all kind of chronic conditions. So it's only going to get worse if we're not able to support them through Medicaid. These cuts that are coming down, I'm a management consultant, so when I saw this, I went and did some research, right? The Republicans have a proposal now that they say could cut 13.7 million, maybe 8 million people will become uninsured now as a result of their latest proposal. And there's 4 million that are going to be uninsured because the Dems passed a subsidy that's going to expire. And if we don't get some action on that, we're going to lose 4 million. 4 million people are going to lose access anyway. And so when people lose access to health insurance, we're already challenged because we don't have enough doctors that look like black folks. There's all kind of data that shows when you go see somebody who looks like you do better, right? And so we're already going to lose that. But then the cuts are also going to impact Head Start, teen pregnancy programs, all those things that we as that black folks need to try to catch up. We're already behind the 8 ball, and now they're going to cut them even more. And furthermore, there's going to cut all these promotion programs, and around obesity is going to be cuts, right? So things that work to keep us from recognizing the danger of obesity and then doing stuff about it are going to be part of what happens. And then the job cuts, 477,000 are forecasted to lose jobs across the country because in the healthcare space where my friend, your former president, Henry, I've been working with 1199C for years. So this is a really dangerous, but I think we have to take action, right? We can't sit back and relax. Underscoring the importance of voting and making a change in the midterms has got to happen because we got to get the Congress back so we can work to get the orange guy, give him a hard time to try to get what he's going to get done. His budget is just horrible, and the Republican budget is just as bad. So we face a challenge, but I think Dr. Stanford talked about we have to work on making sure we maintain our health, right? All the stuff that we need to do as the physicals, the getting a PCP, all those things have to be done. We have to work on making sure we stay as healthy as possible and not wait to go to an emergency room or for services. So I remember we did a study in West Philadelphia looking at trying to make some improvements, and we found that people with diabetes, their interaction to get help was at the emergency room. They would show up with diabetic, limbs that were gangrenous because they weren't accessing help to keep, as we say in the neighborhood, sugar under control. So we got a lot to do ourselves, and these cuts are not helping at all, but Dr. Wynn Baker and I we're doing all the work we can with the African American doctors, the local black doctors group to work to increase the number of black young people that are becoming doctors. So in spite of all the DEI cuts and all those things, we're making progress on that front. So, Senator, thank you so much for organizing this. Senator Street, thank you for all of your work that you do. Senator Haywood, thank you for all the work that you do. And Pastor Waller, thank you for all that you're doing to help our community to try to stay healthy and to fight the good fight.
Thanks, Jim. Again, I started out with this point of why we're having this conversation specifically, all right? And there's a tendency, even though we all know the data, we all know the information, a lot of our folk don't know it. A lot of our folk don't know it. And as we discovered, or if you will, it was concretized during COVID, the issue of trusted messengers was relevant, all right? And so having this conversation, which will be cut and clipped and put out on social media, and the raw footage will be available on the website and all that kind of stuff, is in order for us to get educated, all right, for us to get, to strengthen ourselves, all right, amongst each other, to continue to push forward. If Project 2025 was the baseline in terms of the havoc and hell that they wanted to create, and as Senator Haywood said, the fight is not over. The first iteration that was produced on midnight, was it Sunday night, midnight Sunday night, to the Energy and Commerce Committee, all right, was not as bad as Project 2025, because a lot of people spoke up about this, all right? And if we continue to push this effort, on my drive over here, I'm listening to Senator, Hawley? Yes, from Missouri, who on first blush sounded like he was on our side, okay? There'll be no cuts in Medicaid. He will not support that, right? So the need to continue to educate and to push while we figure out how we service one another, utilizing our creative capacity and networks and what have you, is still necessary. We still must educate, and we still must push back. This does not work. Pastor, we've had this conversation. There's the economics of it, there's the health care of it, but there's the moral conversation as well. We're the richest country in the history of the world. We need to be having conversations about how we expand access to health care, not how we constrict it, how we reduce it. And we have a responsibility, I think, to push back from that vantage point, all right? If food is medicine, then you can't have conversations about cutting the SNAP program. You can't have conversations about cutting our food support programs like SHARE and the rest of them, which is happening. If food is medicine, you can't have that. They are talking about cutting that as well, and we have to push back. And again, the Commonwealth does not have the financial capacity to pick up the billions of dollars of cuts that are projected to come from Washington to Pennsylvania. No state has the capacity to handle this. So, Dr. Posse, going to your networking and conversations with the other black doctors all across the country. I'm assuming you enlighten us, all right? Yes. But this is a conversation that's happening at that level as well.
Yes. Again, it's such an important conversation. It is happening. Go to these programs. We are going to see, again, I said a dismantling of the healthcare system, but we're going to see impact in other places. And so what we also said, the messaging to our community members, right, is access the care that you can now. Some of the conversations behind closed doors are, well, patients are enrolling for Medicaid, but they're not actually going to see their primary care. So why do do we need to continue to provide this? Why do we need to continue to support? So we can do both, right? I agree with you, Senator Haywood, right? Senator Haywood, excuse me, right? The fight is not over. Like, we are fighting. At the same time, right, how are we educating our community members, right, that prevention is paramount, right? You can go get your annual screening. I remind my patients' family members frequently, have you gotten your cancer screening? Are you getting checked for your blood pressure, right? The leading cause for death in women in this country, particularly Black women, is heart disease, 3 times the rate in Black women. Breast cancer, right? Equal in Black and white women, except that Black women are diagnosed generally at stage 3. Why? Because they get screened later, right? It is not just because they are higher risk, because we're getting screened later. So we can also amplify the importance of presenting early, getting prevention, right? That is the role that we can play in educating, but us, right, is elevating this, right, is that this, right, Medicaid is for all. It's for children, it's for mothers, it's for men, it's for adults, it's for elderly, and all of us are impacted by someone in that population, right? So the more that we raise our voice, the more that we can ensure the health and wellness of our community. So National Medical Association is out there, but we are partnering with everyone. That's why I'm so glad that you brought us to the table, because I know to reach out to my behavioral health colleagues, right, mental health colleagues, our faith-based, right? We cannot do this alone, right? We have to do this as a collaborative, and I do think that we can make impact with our voices.
So it's a few minutes before 4, and we wanted to be thoughtful about everyone's time. I don't know if there's any other individuals who want to add something as we close. Pastor Weil, I don't know if you want to add something as well. Reverend Miles, yourself, anyone that you need us as legislators to know about. You need your respective communities to know about, if there are networking and connections that need to occur. Hopefully all of you, and we'll make it easy to send everybody's email address and what have you, so that you all can connect with one another in this process. Ayanna, I know you're going through it right now with the cuts that you just had. We're trying to figure it out, okay? We're trying to figure it out. How much have you lost? How much? Tell the folks here how much your organization has lost.
Yes, so we lost $6 million. So $6 million with the days.
Between when and when?
It was supposed to start April 1st. We found out March 31st. So it's a $6 million a year program for us.
And who are you servicing?
And so we serve southeastern Pennsylvania. So Philadelphia, Bucks, Chester, Delaware, Montgomery counties, 63,000 people a year for Title X services. We have other services as well, but Title X, and with the day's notice, we have 22 providers, 77 sites that had no advance notice that these programs and services would be eliminated. And so we have folks who need this care who no longer have access to it. And things like you talked about the breast cancer screening. So we know that our communities that already are disproportionately impacted by things like breast cancer now can no longer get the screening if they don't have insurance. So it's something that I think, and what I wanted to add to the conversation is just how important it is for us to also educate the community on this, because there needs to be public outcry. And, when public health is going well, then people don't necessarily know what we're doing in the background. And so the more that we can educate our community on the importance of the programs that they receive, but also on the importance of these federal cuts, so that they can start having their voices heard as well. We have to be able to draw the line between policy and impact, and really educating those so that they can understand. It can't just be our voices. It has to be all of the voices of the community. And that's when I think we'll start to see movement. So as we said, we can't just, give in and give up, but instead really getting to those that we have access to so that they can start to have their voices heard as well.
Great. Senator Haywood, you have anything you want to?
I just want to thank everyone. Some very challenging things to hear, but need to be said and need to be heard. And just thank you so much.
Pastor Waller, thank you very much for opening up the church, brother. Appreciate you, man. Really, really, really appreciate you. And thank you all for your participation. we will make sure that we share, as I said earlier, everyone's email address so you can make the connections, so you can follow Reverend Miles as he puts all the little hookups and networks and everything connections together. It's necessary, absolutely, and you all have done an excellent job of making that happen, and others can learn from that process. Hang in there. Please speak up, whatever vantage point that you have. Connect at the federal level to whoever you can connect with. Do not be silent on what is happening. We've been able to prevent a lot of bad stuff from happening. We can keep that going. As Jim Baker said, make sure that everybody's registered to vote. Don't wait till 2026. All right? Do not wait till 2026. Take your political work seriously. And this is the reason why. This is the reason why. If another decision had been made on November 5th, 2024, we'd be having a conversation about how we can expand coverage, how we can provide more health care to more people. All right? That's the conversation. We'd be in this room talking about, we'd be in this room talking about they're getting ready to send us more money from Washington to expand healthcare services. We'd be in this room having the conversation. This is what we'd be having. How do we make sure black people getting access to that money? That's the conversation we would be having. I guarantee you that, because I've been in those rooms before. Farida would be busting my chops. Senator, you better make sure, okay? Am I right, Farida?
You're right.
Okay, all right, okay, all right. We'd be having that conversation. But we're having a different conversation because we were not as engaged politically as we needed to be engaged. And other folks made decisions against their own interests, which they've done for decades, all right? So now we're at where we're at. We got to do what we got to do. We have won before. We can win again, but we got to fight. If we fight, as the Vice President said, if we fight, we win. If we don't fight, it's a loss. It's an L. All right? Thank you all very much.
Thank you.